Hello, everyone, and welcome to our first webinar in collaboration between the World Institute of Critical Care and Emergency Medicine and the International Fluid Academy. I'm very glad to announce this collaboration, and today is our first achievement. And we have very, very pivotal, critical topic today to discuss that everyone wants to know what is the clinical practice guidelines and up-to-date management, which is the fluid management. And fluid is a prescription. And because very recent, the European Society of Intensive Care Medicine had published several guidelines for resuscitation of critically ill adult patients with fluid, and they divided this clinical practice guidelines into three parts. The first part, which we are going to discuss today, is the type of fluid management. Then part two, which we are going to discuss probably by the end of next month, will be the volume of fluid. Then part three will be the de-escalation phase. So please focus today on the type of fluid. I'm very sure that our speakers will try to help you to understand what kind of fluids you want to use in your critically ill patients. Again, we have agreement between the International Fluid Academy and the World Institute of Critical Care and Emergency Medicine to exchange courses and faculty and to do joint research projects and knowledge sharing. And again, when I saw this publication regarding fluid resuscitation, I talked to Professor Manu Malbrain, who agreed to have this very big international up-to-date webinars, and he invited two great speakers. The first author in part one of the guidelines, which is Professor Yaseen Arabi, and the second co-author of this article, which is Professor Belley-Cote. And I invited my dear friend, Professor Ahmed Mady, to moderate the session with us. Here is our agenda today. So me and Professor Manu will just do a brief introduction. Then Professor Arabi is going to try to summarize the ESCAM fluid guidelines. And Professor Ahmed Mady is going to help Professor Yaseen to answer these challenging questions. Then Professor Emilie is going to give us the future improvement and the consensus, if we have one, for fluid management. Then Professor Manu is going to moderate the questions and answers with her. Then I'm going to close the webinar. So very important topic. And here I just have questions for you. So trying to help us to prepare our next webinar. Please try to vote. You have the option now to say yes or no. And the question, as you see, is about the amount of fluid, the volume of fluid we want to give to resuscitate a patient with septic shock. Should we use 30 ml per kg fluid volume for initial resuscitation in critically ill patient with septic shock? I'm going to give you a chance to answer. Please don't be shy and try to answer the questions. It's anonymous, so no one can see who did what. So we have several hundreds already voted, and I think the major vote went with yes. So about maybe 60%, 58% said yes, and 42% they said no. Let's move on to the second question. And the second question is regarding the individualized approach in the optimization phase of resuscitation in septic shock, should we be individualized, personalized, or should one size fits all? And I see people here start to vote, and they start to, we need a question, okay. So they start to vote, and the vast majority, they said yes, we should use individualized approach in the optimization phase for resuscitation, about 88%. So that's very good. So it seems that the vast majority want to personalize this approach. So no one size fits all. Let's move on to question number 4. Should we use a restrictive or a liberal strategies in patients with hemorrhagic shock? Should we be liberal or restrictive in patient with hemorrhagic shock? Again, hemorrhagic shock has different reasons. It could be because of blunt trauma or penetrating trauma, or it could be non-traumatizing. So we have 3 options, and we are going to discuss all of these in the next webinar, not in this one. This one will talk about the type. Next webinar, we'll talk about the volume and the amount. So I see about 50-50. So again, there is a lot of details. So please stay tuned. The next webinar, we are going to discuss these topics. Question number 5. Should we be restrictive or liberal in cases of circulatory failure because of pulmonary embolism? So if you have a patient with massive pulmonary embolism and circulatory shock and need resuscitation, should you be liberal or restrictive? Again, the vast majority, about more than 80%, are voting for restrictive approach. Very nice. Again, stay tuned to try to help you to answer all of these questions. Number 6, the question is, should a restrictive or liberal strategy be used in patients with cardiac tamponade? So again, a patient with pericardial effusion and cardiac tamponade, and should you give him a lot of fluid, or should you be restrictive? Again, the definition of restrictive and liberal, we are going to tell you more about this definition in the upcoming webinar. And of course, about 84%, 85% vote for restrictive, not liberal, and cardiac tamponade. 2 more questions. Question number 7, should a restrictive or a liberal strategy be used in cases of left-sided heart failure with cardiogenic shock? So we talked about pulmonary embolism. Then we are talking right now about left-sided heart failure, cardiogenic shock. And again, about 90% said we should be restrictive. Last question, what about patient with ARDS, with circulatory shock? Should we be restrictive or liberal in this patient with adult respiratory distress syndrome? Again, about 90% of the attendees vote for restrictive. So with that, again, what we are doing and what we are trying to do is we are going to help you to get the knowledge, but the knowledge has no value until you put it in practice. And not only that, but also the great aim of education is not the knowledge itself, but the action. So hopefully this knowledge we are giving you today is trying to help you to improve your patient care, the standard of your patient's care and the practice. Again, thank you so much. And I'm going to stop sharing here, and we'll let Professor Manu to introduce the webinar and the speakers.
Thank you so much for this excellent introduction and preparation for part 2 of this webinar series. For the webinar today, I would like to ask everyone, if you're before a screen, just to scan the QR code or you go to a browser in Safari, Firefox, Chrome, you go to menti.com and you enter the code 62329520. So just open a browser, menti.com, and enter the code 62329520. So we will wait a little bit for everyone to join. If you want, you can leave an email address if you want to stay informed of updates from WICCEM and the Fluid Academy. So let's start with some warming up. You can always join menti.com and enter the code 62329520. Okay, so we see majority doctors, students, specialists, pharmacists. There are no lost tourists so far, which is good. And we will learn more about our audience in the next questions. So if you're a doctor, can you tell us what is your basic specialty, or maybe in some countries you have intensive care as a separate specialty, or sometimes it's in combination with anesthesia or internal medicine or surgery. So we see a lot of intensivists, pediatrics, which is very good. I have to say that the webinar now and the guidelines are for adult population, so not for pediatric ones. Okay, so moving on. So now we would like to know how many years of experience do you have. So if you're a student, you just click on the 0 button. So it's a mixed audience. We have some junior profiles, but also some colleagues with a lot of experience, and no one retired so far. So no tourists and no retirements. So quite knowledgeable audience. So where do you come from? I would suppose that we have a broad audience from Europe, Africa, Asia, a lot of Middle East. We have some from North South America. I assume in Oceania, Australia, it's probably too late in the evening already. So mixed audience, a little bit from all over the globe. So now, as the same questions, I think it's about 8 questions. So, and be honest, just answer exactly what you do at the bedside. So what fluid do you use for volume expansion in adult critically ill patients in general? Patients in the ICU, we see we have about 88 votes. I'm gonna show the results. Okay. Okay, so this is what I would have expected. Quite a lot of normal saline. We will discuss whether it's normal or abnormal. Ringer is interesting because it actually has a very huge chloride content, and Ringer's lactate balance solution. Okay, a little bit of colorate. So now the questions are always the same, but now it's for critically ill patients with sepsis. So what is your preferred fluid in patients with sepsis, septic shock? And you can choose from saline to balance solutions to colloids. So 126 responded. I'm gonna reveal the results. Okay, so it's a bit about the same, I would say. I notice a little bit more plasma light here, but still about 50-50 saline versus balance solutions, a little bit of albumin. Move on to the next question. I'm going to hide the results. So now the patient has acute respiratory failure. Remember Amr's questions with regard to liberal restrictive fluids. So now patients with acute respiratory failure. Vote now. So I think it's always the same choice and options. Okay, so here I think we see a little bit more of albumin. and we can discuss whether it's albumin 4%, 5%, 20%. Okay, we move on to the next patient category, and now we have critically ill patients with traumatic brain injury. So what is the fluid of your choice for resuscitation volume expansion in traumatic brain injury? Vote now. Okay, 100 voted. Let's have a look. And here, clearly, majority now is saline, but we still see some albumin. So this is to be discussed during the Q&A, and also some ringer. Ringer is a little bit hypotonic with a sodium of 130, and we will get into that. So now we have a patient with AKI and a potassium of 6. And remember that most balanced solutions also contain potassium. I don't know whether we asked whether there were any nephrologists in the room, but nephrologists tend to give saline to these type of patients, simply because there is no potassium in the saline, but also this we will discuss later on. So majority saline, and we will see at the end of this webinar whether that's the right answer. So now let's move on to patients with trauma at risk of bleeding. Be aware that some of the balanced solutions have buffers like citrate. Sometimes there is calcium in these solutions, whereas normal saline is just sodium and chloride. Vote now. Let's have a look. And here now we see in these patients majority goes for Ringer's lactate. Okay, and I think we are at the last, or before last, so now it's a group of patients with cirrhosis, and the guidelines will give a recommendation for all these type of patients that we will hear in the lectures. Okay, so now for cirrhosis, we see a clear preference for albumin solutions, and then a mixture of balanced and normal saline. And here, one of my favorites, severe acute pancreatitis with intra-abdominal hypertension. So what is your fluid of choice if you want volume expansion? Vote now, quick, and then it will be my pleasure to introduce Professor Yaseen Arabi. Okay, 100 voted. Let's have a look. So here we see in severe acute pancreatitis a mixture of saline, balanced, and albumin. Okay, I think this was the last question. No, here we would like to ask whether you have implemented fluid stewardship in the same way like you probably have an antibiotic stewardship program in your hospital. So I think it's good to hear that some do have, some will do in the future or are working on it. Nice to see. So today we're going to talk about fluids, why they matter, because they can be life-saving. And we should think fluid stewardship because they have indications and contraindications and complications like organ failure and electrolyte and acid-base imbalances. We must understand that about 80 to 90% of all hospitalized patients get IV fluids, and that 20% of patients, 1 in 5, suffers from deleterious effects due to inappropriate fluid use, too little, too much. Studies have shown that from all the fluids, only 6% is resuscitation fluids and 30% is fluid creep to administer other drugs like antibiotics. A recent survey we performed showed that the knowledge of healthcare providers on fluid composition, homeostasis, indication is poor with a score below 50%. So these are the problems with IV fluids. So I think it's time for fluid stewardship to reduce inappropriate fluid use, prevent complications, and improve patient outcomes, aligning with existing guidelines. And today we're going to discuss the European Society guidelines. So it's my pleasure to introduce Professor Yaseen Arabi, who has a very long track record, and he is chairman of the ICU department, medical director, respiratory services, and professor College of Medicine at the King Saud bin Abdulaziz University for Health Sciences at King Abdullah International Medical Research Center in Riyadh, the Kingdom of Saudi Arabia. He's a recognized leader in critical care research, has done multiple studies on COVID, conducted the PREVENT trial, the Miracle trial, and the PERMIT trial. His leadership has been recognized with multiple awards, and his group has published major research paper. I think he has published over 600 peer-reviewed papers, including 38 in the New England Journal of Medicine, JAMA, and The Lancet. So it's a real honor and a pleasure to introduce you, Professor Yaseen Arabi, and to summarize us part one of the fluid guidelines of the European Society.
Thank you very much, Prof. Malbrain, for the introduction and for arranging this fantastic webinar. Very well organized, so I'm very grateful to be with you today.
You're muted, Yaseen.
Can you hear me now?
Yes, perfect.
Yeah, thank you very much, Prof. Malbrain, for the introduction and for giving me the opportunity to be with you in this fantastic webinar. Very well organized, so much appreciated. I'll be summarizing the European Society of Intensive Care Medicine guidelines on fluid choice. I was privileged to be the clinical chair for part one, which deals with the choice of resuscitation fluid, along with Prof. Emilie, who's going to be discussing the methodology. She was a method chair for this guideline. So the scope of these guidelines is adult critically ill patients, and it addresses the most commonly used fluids, crystalloids, including isotonic saline and balanced crystalloids, and also albumin. We will not discuss starches or gelatin. The scope again is for fluid resuscitation. You correctly mentioned that the fluid in the ICU very often is used for many reasons, but we're going to be focusing on the fluid resuscitation, the main indication for fluid really. The methodology of grades goes through multiple steps. Prof. Emilie going to talk about this a little bit more, but it starts with formulating questions, and our group formulated 11 questions that I'm going to go over them, then reviewing the literature, putting the literature together in an evidence profile, then grading the evidence, and then putting all this together in guidelines. And one of the important things that the guidelines take in consideration, not only the evidence, but also takes in consideration other contextual issues such as patient values, preferences, cost, equity. And I think this is will be very evident in these guidelines. I think very important distinction and important to understand the language and terminology used in guidelines. So there's a strong recommendation and there's conditional recommendation, sometimes called weak recommendation. So strong recommendation is a recommendation in which most patients and clinicians would like this choice. And when you have a strong recommendation, this is a recommendation that could be used as a policy. But a conditional recommendation is most people would accept it, would think it's a good idea, but some people may not agree with it. And in that case, it will not be appropriate to use as policy. So it's preferred to use A versus B, but it's not mandatory. Strong recommendation, you should use A versus B. These are the 11 questions that are covered in our guidelines. 6 of them are related to albumin versus crystalloid, 4 related to balanced crystalloids versus isotonic saline, and 1 covers hypertonic versus isotonic fluids. So again, for the guidelines, we define the outcomes upfront, and these are the outcomes that we prioritized: short-term mortality, need for renal replacement therapy, and you see the rest of the list. And for the traumatic brain injury, we added extended Glasgow outcome scale. So let's start with albumin or crystalloids. What should we use in the ICU? Albumin or crystalloids? And the first group is adult critically ill patients in general. So in general, in your ICU, would you use albumin or crystalloid? And we're looking at outcomes that are mentioned a little earlier: mortality, need for renal replacement therapy, etc. For this question, we identified 16 randomized controlled trials that included more than 12,000 patients. And as you see in this first plot, the relative risk is 0.98, with a confidence interval between 0.93 to 1.04 crosses 1 on both sides of 1. This is the evidence profile, which shows the effects on different outcomes. The mortality, here's the renal replacement therapy, relative risk 1.04. And for other duration of mechanical ventilation, ventilation-free days, etc. In general, the evidence profile shows that it does not favor albumin or crystalloid based on these randomized controlled trials. Now, when you take in consideration a few other points, so we have albumin and crystalloids, they don't offer advantage clinically, but you have albumin that costs 27 times more than a crystalloid based on existing studies. Albumin may not be available in many places, and in places where they are low resource, the wide use of albumin could deprive other patients from healthcare resources, so issue of equity. Taking this in consideration, the panel made a recommendation or suggestion for using crystalloids rather than albumin for volume expansion in adult critically ill patients. This was a conditional recommendation based on moderate certainty of evidence. How about sepsis? Now, patient with sepsis, albumin may make even more sense, because albumin, with its oncotic property, you would think that it will stay in the intravascular space for a longer period of time. It will have a more volume sparing effect. So you give albumin, doesn't leak too much to the interstitial space. Sounds like a very good idea. Now, based on physiologic studies, albumin versus crystalloid expand the intravascular space 3 times more. But when it was evaluated in clinical trials, it did not appear to be as good as it's in normal people. Based on the SAFE trial, the expansion for albumin versus crystalloids is on a ratio of 1 to 1.2 or 1 to 1.6. So yes, it has a little bit more volume expansion property, but is not as good as we think based on physiologic studies. Nevertheless, I think what matters for us is what's shown from the clinical trials. And the clinical trials shown here, we have 9 clinical trials, almost 5,500 patients. And the relative risk for this is 0.96, confidence interval from 0.89 to 1.02. For renal replacement therapy, the signal goes the other way, although again, not statistically significant, 1.04, 0.88 to 1.24. This is the evidence profile for taking consideration also ventilator-free days, duration of mechanical ventilation, length of stay, and others. And if you put all this together, the balance of effect does not favor albumin or crystalloids. And because of the consideration that I mentioned earlier, including cost, availability, equity, the panel suggested that for patients with sepsis, we suggest using crystalloids rather than albumin for volume expansion. This is a conditional recommendation based on moderate certainty of evidence. That sounds great, but I think there are certain patients who have sepsis might deserve a slightly different approach. And the panel discussed 3 groups, which are probably at in our practice and bedside, we always consider. So how about patients who have low albumin level? How about patients who already received large amount of crystalloids? How about patients who are in septic shock, not only sepsis, those are in septic shock? And unfortunately, we don't have strong evidence that can help us making a conclusion or recommendation for these subgroups. And among the panels, which the panel was really some of the top expert people in the world in the field of fluid, there was considerable debate and considerable variability in practice in these groups. So we documented that this issue still is unsettled, and there's considerable variability, and certainly these are good areas for future research. How about those patients who have ARDS, or acute respiratory failure? And here you have somebody with ARDS, the capillaries are leaking, and probably it makes some sense to use albumin, or you would think that giving albumin will be good because it will reduce the pulmonary edema. And in fact, we know some studies that use albumin and furosemide that show some benefit in oxygenation. If you look at the evidence profile for this group, there were 3 studies, mainly subgroups of other trials, not very large, did not show difference in the outcomes and mortality, ventilator-free days, or renal replacement therapy. And based on this, again, the recommendation was to suggest using crystalloids rather than albumin for volume expansion in patients with acute respiratory failure. Conditional recommendation, but based on very low certainty of evidence. Next group is patients with traumatic brain injury. Now, patients with traumatic brain injury, what you want is to maintain the cerebral perfusion, and with fluid and sometimes with vasopressors. But so albumin or crystalloids, both sounds physiologically makes sense. But we have study the SAFE trial, subgroups from the SAFE trial showed harm with albumin. And when we evaluated the evidence for this question, we found only the data from the SAFE trial. And this SAFE trial showed that mortality was higher with albumin compared to normal saline or isotonic saline. Mortality was higher, and subsequent studies showed that long-term outcomes were worse. Another physiologic study based on the SAFE trial showed ICP was higher in the patients who received albumin. It's important to note that the albumin that was used in SAFE trial was hypotonic, had a osmolarity of 260. So it has been postulated that the worst outcome is not related really to the albumin, but to the hypotonicity of the fluid that's used. However, the signal, this is the only evidence we have, and it's a signal of harm. So it's really, really difficult to ignore. And based on this, the panel suggested using isotonic saline rather than albumin for volume expansion in adult critically ill patients with TBI. I want you to note here that we start with the PICO saying albumin versus crystalloid. We ended with recommendation of isotonic saline, not crystalloid. And the reason for this is there are no studies using balanced fluids, and probably there will be no studies using balanced crystalloids in traumatic brain injury. We'll mention this in a subsequent question. Isotonic saline, and I'm not using the word normal saline, I'm using isotonic saline or 9% saline. It's probably the preferred fluid for patient traumatic brain injury. Certainly preferred over albumin, and as I'm going to show you later, is preferred over balanced crystalloids. How about patients who have tendency to bleed? Those who have in the perioperative period patients who are bleeding already or patients at high risk of bleeding. We know that when you give a lot of fluid, you induce coagulopathy because of dilution. The more fluid they give, the more dilution you cause, and this has been shown in studies. Therefore, giving crystalloids, which is more volume, may induce more coagulopathy. Also, on the other hand, colloids are known to cause coagulation defects, particularly starches. Albumin does also, but less so than starch. So both those sides, crystalloids and colloids, potentially can cause coagulation problem. So we evaluated this question. We found 9 clinical trials, mainly in the perioperative period of patients with vascular surgery, but some other surgeries as well, and could not find, based on the evidence profile, there was no signal suggesting this or that albumin or crystalloids. There was no much difference also in blood transfusion, maybe tiny, but not clinically significant. Based on the cost and based on the availability, we suggest using crystalloids rather than albumin for volume expansion in adult critically ill patient in the perioperative period and those who are bleeding or at high risk of bleeding. This is a conditional recommendation with a very low certainty of evidence. How about the cirrhotic patients? Cirrhotic patients are a special group of patients. These are patients who have complex hemodynamic changes. They have relative central hypovolemia. They have hypoalbuminemia as well. And the use of albumin is known among hepatologists, as you know, and it has been studied in many indications, cirrhosis after acidic fluid removal, in hepatorenal syndrome, in patients with spontaneous peritoneal bacterial peritonitis, and generally has shown some favorable effect. In critically ill patients, we found a systematic review of 3 studies, not very large in total, less than 500 patients. And in this small study, there was no statistically significant difference, although the signal was favoring albumin in terms of mortality and favoring the albumin in terms of renal replacement therapy. So based on this, the panel suggested using albumin rather than crystalloids for volume expansion in adult critically ill patients with cirrhosis. This is a conditional recommendation, very low certainty of evidence. We'll move to the second category, balanced crystalloids or isotonic saline. Probably isotonic saline is the most common fluid around the world, used around the world. I mean, if you take globally, this is probably the most commonly used. And it's fantastic, it is cheap, it's available, but it has too much chloride. And it can cause hypochloremic metabolic acidosis. And this hyperchloremic metabolic acidosis, and now we recognize it can induce acute kidney injury. And therefore, the interest has increased with the balanced crystalloids. And what we mean by balanced crystalloids are a fluid that has lower chloride concentration, but use other organic anions, such as lactate, acetate, gluconate, or malate. And also, they instead of the high sodium, also they use other cations such as potassium, calcium, and magnesium. So as a result, these fluids, less chloride, pH is more towards closer to normal, not exactly normal, but it's closer. The tonicity also is closer to normal. So should we use them in general ICU patients? We have reasonably good amount of evidence now. This is a systematic review from the New England Journal of Medicine Evidence. Large number of studies, large number of patients, total of 35,000. And what you could see here, on mortality, the effect, the relative risk is 0.96, confidence interval 0.91 to 1.01. Yes, it's not slightly significant, but it's very, very close. So it really favors the balanced fluids. Yet it's not slightly significant, but it favors the balanced fluids. Then we have the systematic review for individual patient data meta-analysis published in Lancet Respiratory. And this one used Bayesian analysis, and it showed for mortality, use of balanced fluid had a probability of benefit of 89%. So 89% probability of benefit with balanced fluids versus crystalloids. This is the evidence profile, generally favoring the balanced fluids in mortality, in renal replacement therapy, both in the same direction and consistent finding. And based on this, we suggested using balanced crystalloids rather than isotonic saline for volume expansion in adult critically ill patients. There are important remarks here that we need to keep in mind. Now, you could tell me, in my hospital, I don't have a lot of these balanced fluid. Maybe I have a little bit limited supply. I don't have a lot of LR. I don't have a lot of plasma light. So in that case, probably you should use it wisely. Maybe you should prioritize using balanced crystalloids rather than isotonic saline in patients who require a large amount of fluid, those who have hyperchloremia, those who have acidosis. These are the ones you should use balanced fluids. But other patients, you could use saline. You could tell me, in my hospital, I don't even have balanced crystalloid. I don't have LR. I don't have plasma lights. And this probably in many places around the world. I would tell you then use isotonic saline. It could be say life-saving for many patients. So it is okay. If you don't have balanced crystalloids, use isotonic saline. Also remember that maybe in certain conditions, you want to use saline rather than using balanced crystalloids. So imagine a patient who is hypochloremic or patients who have metabolic alkalosis. Then in these cases, using saline makes more sense. How about in patients with sepsis? Patients with sepsis are a specific group of the critically ill patients. They are high risk of mortality. They are high risk of acute kidney injury. So should we use balanced crystal or saline? This has been tested in these systematic reviews, and the signal is probably the same direction, even probably more significant, favoring balanced fluids, both in mortality and renal replacement therapy. Based on this, the panel suggested using balanced crystalloids rather than isotonic saline for volume expansion in patients with sepsis. How about in TBI? This is a really important group. So patients with TBI this has been studied in several subgroup analyses. I think one important issue in TBI is the fluid osmolarity. And the low fluid osmolarity can increase the cerebral edema and worsen the outcome. Let's remember that isotonic saline has osmolarity 308. So it's actually slightly hyperosmolar, while the balanced fluids are generally lower osmolarity, slightly lower than normal. And in case of plasma light 148, it's 294. And for LR, it's around 273. So it is slightly hypotonic. If we look at the evidence for this group, there were 3 RCTs, and these studies, putting them together, showed that isotonic saline was associated with better outcome compared to balanced fluids, less mortality compared to balanced fluids. Now, one thing to keep in mind that these studies use balanced fluids mainly plasma light, not LR. Not plasma light, not LR. So what the panel made a suggestion to use isotonic saline rather than balanced crystalloids for patients with TBI. Most of the evidence is based on RCTs that use balanced crystalloids with near normal osmolarity, plasma light. So don't use LR in TBI because it's even more hypotonic. So if plasma light is not good, LR probably is even worse. Don't use LR for patients, especially with fresh traumatic brain injury, because it's hypoosmolar. isotonic fluid is your choice here. How about patients who have already acute kidney injury? We are saying hyperchloremic metabolic acidosis can cause kidney injury. So what about the patients who have already some kidney injury? We looked at the evidence for this. There's only small randomized controlled trial in patients with existing kidney injury, but there are several studies in patients with recent renal transplant, and these all suggested better outcome with balanced crystalloids compared to isotonic saline. So we suggested using balanced crystalloids rather than isotonic saline in these patients. Conditional recommendation, very low certainty of evidence. The last question is about small volume hypertonic versus isotonic fluid. And hypertonic fluids has been used in battlefield, has been used in pre-hospital setting because they are small volumes, so easy to carry. And also they don't cause a lot of edema, so that's another advantage. In critically ill patient, we don't have a lot of studies, but when you combine the existing evidence together, the evidence profile does not favor small volume hypertonic versus isotonic fluids. Given these fluids have kind of heterogeneous concentrations, availability, and maybe different cost, the panel suggested that we stick with the standard isotonic fluids rather than small volume hypertonic fluid for volume expansion in critically ill patients. This was a conditional recommendation based on very low certainty of evidence. This concludes the 11 questions that were addressed in our choice of fluid guidelines. Thank you.
Thank you very much, Prof. Yaseen. Actually, thank you very much for being with us here as an expert, which is mapping the practice of critical care worldwide. We are really proud to have you in the webinar and Saudi Arabia to help us in your guidelines. You are contributing in the helping us to take the decision of the management of such patients, especially in these critical situations. Actually, I'd like to announce for all attendees, we are focusing in this webinar on the types of the fluid, because I can see a lot of the questions in the Q&A just asking about the fluid responsiveness, the amount of the fluid, the resuscitations. So if you allow me, I will skip those questions, which is not focusing on the scope of the webinar today. Let me, because we're running out of time, just if you allow me, Dr. Yaseen, there is some few questions touching the types. I can say, for example, from Dr. Abdul Hamid, he have a lot of questions, but one of them, and let us see, have the scope of the webinar today. He mentioned that strategies of fluid support therapy, same or different based on the patient status, whatever sepsis or cardiac. I will consider fluid supportive therapy as a type is one of them. So type of the fluid for different patient status.
That's a great question. And yeah, so the type of fluid may be a dynamic point. You may want to, so initially you start with certain type of fluid, and then you may consider something else later. And in fact, there are some people suggest that we use isotonic saline and balanced fluids based on chloride measurements. So if the chloride measurements are normal, then isotonic fluid is okay. If you start to see your chloride going up, then you switch. But this has not been validated in studies, but it's one of the hypotheses. As I mentioned, also, there are some, at least in surviving sepsis campaign, for example, in the previous iteration, if you give somebody very large amount of crystalloids and the patient's not responding, you may want to consider albumin. So I agree, it is a dynamic. It's not like one based on a special condition, you stick with one type of fluid. It's require continuous reassessment.
Great, thank you, Prof. Let us take another couple of questions. One of them from Sayed about cirrhotic patient. He said once the albumin is expensive, we have another alternative.
Good question. Most of the studies on cirrhosis are on albumin. The starches, I'm not aware of the studies, but I think the risk of the starches is the coagulation and the induction of kidney injury, which is common in cirrhotic patients. So if you don't have albumin, I would go for crystalloids, frankly.
If you allow me, Prof. Yaseen, I have a question from my side that you didn't address in the guidelines how we can do like a combination therapy, especially if you can mix between albumin and the crystalloid in some scenarios.
So
All of
of
them
course, as
are,
you know, I mean, the PICO, the grade methodology identifies specific questions, and these specific questions based on the existing evidence. Of course, there will be many other questions that are relevant, but there are no literature, so there's no point to address them in the guidelines. Regarding the combination, we touch on this briefly. As I said, we discuss whether patients who receive crystalloids should receive large amount of crystalloids should receive albumin, and there was tremendous controversy about this topic. There are different opinions, and it really reflects the lack of evidence on this area, and it reflects the different practices. I think if you survey the people who are on this webinar, you will find people would use albumin. Some people will not use albumin. Some people use 20%, some use 5%, etc. You'll see all different combinations, really reflecting the lack of evidence on this topic.
yeah, and again, even Muayyad addressed also the same combination, but with different crystalloids. He mentioned any study done in combination of lingar lactate and the 3% versus normal saline with the 3% in TBI, combination of the crystalloids.
I'm not aware of randomized controlled trials addressing this point.
Actually, I think because we are running beyond the time, so I'd like to apologize for all people who just drop their questions in the chat room. We will try. I think Dr. Amr and Prof. Manu, he will promise us, Prof. Amr, he will promise us that we can address those questions, because a lot of questions are about fluids, about types, about this resuscitation, about monitoring, about the difference between different types of the balanced solutions. So I think it's not the scope of the time now. So I'd like to thank you, Prof. Yaseen, very much for being with us today. And thank you for very valuable guidelines and the lectures. Great. Without further due time, just let me present the next speaker. Actually, we have the honor to present Prof. Emilie Belley-Cote. Prof. Emilie, she obtained her medical degree from University Sherbrooke. After she finished internal medicine and cardiology training, as well as his master's degree in clinical science, the research profile on the same university, she completed her critical fellowship program in McMaster University. And in 2019, she completed her PhD at the same University of McMaster. She is now an associate professor of the Department of the Medicine at the McMaster University. She practiced clinical care cardiology in the cardiovascular intensive care and the coronary care unit at the Hamilton General Hospital. Her interest of research mostly around the preoperative cardiac surgery areas, around the knowledge and the guidelines development. At this stage in her career, she has more than 300 publications, actually, including in the landmark journals like New England Journal of Medicine, Lancet, JAMA. So I'd like to welcome Prof. Emilie to being with us today. The floor is yours, Prof. Emilie.
Happy Monday, everyone. I'm delighted to present today in this webinar on mastering fluid management, insights from the latest guidelines. The topic I will specifically discuss is future improvement and consensus around fluid management. First, I have a few conflicts of interest to disclose. They are unrelated to the topic we are discussing today, but I have received unrestricted research grants from Abbott Laboratories, Bayer, BMS Pfizer, Roche Diagnostics, and consulting fees from Trimatic Therapeutics. I am supported by the Clive Kieran Mid-Career Award. I think a good mindset to start this discussion with is inspired by this quote from Albert Einstein: "The definition of insanity is doing the same thing over and over again and expecting different results." So today we will take a look at the body of evidence addressing the type of fluid choice in the intensive care unit and see how we can do better in the future. So this is the body of evidence we worked with when building the guideline that we're discussing today. So 3 domains. The first domain is albumin versus crystalloids. The panel ended up coming with 6 conditional recommendations. 2 were informed by moderate certainty evidence, and 4 by very low certainty evidence. Second domain was balanced crystalloids versus isotonic saline. 4 conditional recommendations. 2 were informed by low certainty evidence and 2 by very low certainty evidence. The third domain was hypertonic saline versus isotonic saline. 1 conditional recommendation that was informed by very low certainty evidence. So you may wonder, because you read the papers like I do, like, wow, all these like big New England Journal of Medicine trials, how come we end up with very low, and moderate certainty evidence? So that's what we're going to dive in a little bit for the next few minutes. So the guideline we're discussing was built within the GRADE framework. So there's quite a bit of work that goes into these guidelines. Each question or PICO is informed by a systematic review and meta-analysis if it is appropriate to do a meta-analysis. Within the GRADE framework, randomized controlled trials start as high certainty evidence and can be downgraded for several factors that we'll go into. And observational studies start as low certainty evidence and can be either downgraded or upgraded based on some domains that we will look at now. So here are the domains that we assess when looking at the certainty of evidence within the GRADE framework. The first 5 domains are domains for which we would downgrade the certainty of evidence. So a trial, for example, or like body of trials would go from high certainty of evidence to moderate if we downgrade in 1 domain, to low if we downgrade in 2 domains, or to very low if we downgrade in 3 domains. Meanwhile, like if we were working with observational data, we could go up or down because the last 2 domains could allow you to increase the certainty of evidence. All right, so the first domain is risk of bias. The second domain is inconsistency, and that can be clinical inconsistency. So like the intervention was delivered differently, or the population was different. Indirectness would be the third domain, and that is if, for example, you're using data from critically ill patients in general to address a PICO in septic patients, or if you're using sepsis data to inform a question about vasoplegia after cardiac surgery. So that would be indirect data, and that would lower your certainty of evidence. The fourth domain, which is really a key domain, is imprecision. And we will dive a bit more into imprecision later, but this is like how precise is your confidence interval around your estimate of effect. And can you really ensure that you have ruled out a meaningful improvement in outcome or worsening in outcome? The fifth domain is publication bias. As we know, like clinicians and journals get a lot more excited about publishing trials that are quote unquote positive or like demonstrate potential benefit of an intervention or harm. Much less excited about publishing small trials that show no difference or are neutral, right? So publication bias is when we can find evidence or suggestions that small, neutral, or negative trials are not published, which may lead to like an overestimation of the estimate of effect. The 2 domains that we can increase the certainty of evidence for are if there's a large magnitude of effect, or if there is a dose response gradient. That is a lot more relevant for observational studies. And the guidelines we're discussing today were limited to randomized controlled trials, so I won't go into any more details for this. So this is not just like talk, we actually go through that process. So this is a GRADE evidence summary. So you can see like this was the one for balanced crystalloids versus isotonic saline in critically ill patients in general. So you can see that for each outcome, like we actually go through this, right? So like each kind of row is an outcome. So you have mortality, then you have renal replacement therapy, vasopressor free days. And for each of these outcomes, we go through each of the domains I just outlined, and we make a judgment as to whether we need to downgrade in that category. And then it generates a certainty of evidence for each outcome, right? So you can see that, for example, for balanced crystalloids versus isotonic saline in critically ill patients in general, for mortality, we had a high certainty of evidence. Why is the recommendation based on moderate certainty of evidence? It is because we cannot use, we usually will say that the body of evidence is the lowest of the critical outcomes. So here you can see that renal replacement therapy is informed by moderate certainty evidence. Therefore, the body of evidence is of moderate certainty. So not only do we, like, in theory, go through this process, we actually go through this process also in practice with the panel. There is a panel of experts really weighing in. So why did we lower the certainty of evidence for the choice of fluid in the intensive care unit? The key issues in the body of evidence are, first, imprecision. And really, that pertains to both uncertainty about the magnitude of effect, but also often, like, we could not rule out that there might have been a meaningful improvement in patient outcomes or worsening of patient outcomes with the intervention, right? So that is really like our decisions, like for our patients, would vary if the true effect was at the ends of the confidence interval. The second factor that contributed to lower certainty of evidence is inconsistency. And that inconsistency within the body of evidence was both statistical, so heterogeneity as assessed by the I-square, but also sometimes clinical in how the intervention was delivered within the trials. And like that can be, for example, like the volume of albumin, right? Or using albumin like 20% or 25% versus 5%. So this is inconsistency, and that contributes to lowering the certainty of evidence. Another important factor was risk of bias, and we really thought that the body of evidence was affected by risk of bias, mostly for the PICOs or the questions that related to subgroups. So for example, patients with acute kidney injury or patients with ARDS. Because these were often not pre-specified subgroups and there was no stratification of randomization based on these baseline characteristics, we could not ensure that there was a preservation of the benefits of randomization. So we had to decrease our certainty of evidence there. That being said, like it's not all about stats and numbers and studies, right? There is also some holistic factors that go into generating the recommendations, and that comes through the evidence to decision framework. So within the guideline process, once we've summarized the evidence, really the panel, which is composed of like experts from around the world, like comes together virtually, usually nowadays, and goes through some other domains within the evidence to decision framework to inform the strength of the recommendation. And so these domains are like, is the problem a priority? What are the desirable effects? What are the undesirable effects? What is the certainty of evidence? So this is similar to what we've talked about already, right? But let's look into the rest, right? So we also assess as a panel the values, like, do we think patients with different values may make different decisions in light of the data? What is the balance of the desirable and undesirable effects? What are the resources required to implement the intervention? Is the intervention cost effective? What would be the impact of implementing this intervention on equity? Is the intervention acceptable? Is it feasible to implement the intervention? So you can see that we really take a holistic look at the question to inform the recommendation. So this is what this looks like. So again, this is the question regarding balanced crystalloids versus isotonic saline. And you can see that like as a panel, we went through each of the domains and we made judgments. What factors contributed to conditional recommendations being issued for the choice of fluid in the intensive care unit? So the main factor was the certainty of evidence. So for all of these questions, we did not feel like we had high certainty of evidence. There was also a lot of uncertainty about cost effectiveness. And that's particularly relevant when we talk about albumin, and even in some settings, balanced crystalloids, which are a little bit more expensive in high-income countries, but like this difference is even more meaningful in low-income countries. And that leads also to concerns for equity, right? If we were to make a strong recommendation or like to issue like a strong recommendation for albumin or crystalloids, it would have a meaningful impact on equity around the world. So what do conditional recommendations mean? Because like it's kind of a nice word, but like as clinicians, we need to know what does that mean for us, right? They used to be called weak recommendations. Often we call them suggestions. So it is basically recommendations when we have lower confidence in the estimates, when we feel like there is a close balance between the risks and benefits of an intervention. So what are the implications of a conditional recommendation? So it means that there is probably variability in patients' preferences. While most patients would want the intervention, many would not. So we need as clinicians to ensure that the decision aligns with our patients' preferences. And that's where decision aids can be helpful. I fully acknowledge that like this is much more challenging in the intensive care unit when deciding on 2 bags of fluid for someone who's intubated, ventilated, and whose life is acutely in danger. So of course, we don't often like have like extensive discussions with patients about their preferences, and we don't have decision aids informing our decisions. But as clinicians, like there is a little algorithm going in our head, right? So a conditional recommendation means that there is room for that clinical judgment. There is room for tailoring our choices to the patient. I think it's helpful to contrast that with a strong recommendation. So a strong recommendation, I'll give you an example from my world, the cardiology world. So aspirin in acute MI, right? So we have a very, very strong body of evidence, high quality evidence that this improves patients' outcomes with a risk that is clearly lower. So benefits clearly outweigh risks, hassles, and costs. And when we are facing a strong recommendation, like we don't need to ponder a lot. Like we just do it and we tell the patient we're doing it, right? Like I don't discuss with my patients like the pros and cons of giving them aspirin when they're having a STEMI. I just give it to them. So when facing strong recommendations, the implications are that there is little variability in what patients would want. And these recommendations can really be used as quality metrics, right? Because it's something that most clinicians would do in their practice. So coming back to the body of evidence for the choice of fluid in the ICU, like again, look at this like certainty of evidence. Moderate, very low, low, very low, very low. So really like we can do better. And how can we do better? So in terms of future improvement, I think we can generate large, definitive randomized controlled trials with embedded cost effectiveness analyses. It would be helpful in future trials to pre-specify subgroups of interest and even consider stratifying for these characteristics so that we maintain the benefit of randomization when looking at these subgroups. I think we need to really think as critical care physicians about building trials with pragmatic designs that are embedded in clinical practice so that we can really enroll patients in the early stages of their disease process and inform the whole spectrum of the course of the patient. While going through the guideline, we also identified some research priorities. So there are areas that often lead to a lot of discussions. Maybe we can spend some time discussing these after I'm done presenting. But we don't have like high quality data to inform these. So the impact of different concentrations of albumin, the different types of balanced crystalloids, right? We know they're probably better, but what about plasmolite versus Ringer's lactate, right? What is the interaction of the effect of albumin with volume of crystalloids administered? We don't have a lot of data around the choice of fluid in the different phases of sepsis treatment, right? Like very early resuscitation versus later in the course. There are key subgroups where we need to generate better data. So there's a subgroup of patients with acute kidney injury or chronic kidney disease, patients with ARDS, patients with traumatic brain injury. And I really want to emphasize also the importance of cost effectiveness analyses, but not just like in general, but also ensuring that we capture different healthcare settings, not just high income countries when conducting these cost effectiveness analyses. So I want to thank you, and I'm hoping that we can have a very interesting discussion.
Thank you so much, Emilie, for this very nice overview on how to get a consensus, the problems with bias, the lack of hard evidence, and some options for the future. I have a question. We learned from previous big fluid trials and pragmatic trials that even if they are powered enough, the results are usually negative. Isn't the problem in the protocolized care, meaning that it's like one size fits all, and we know that not all patients are the same? There is this idea to move more to personalized care, which would be the Surviving Sepsis Campaign adjusting MAP, not 65 but 75 if the patient is known with hypertension, taken into account autoregulation, or maybe individualized care, which is exactly as you say. You have the different phases from resuscitation, optimization, stabilization, evacuation, and it's dynamic depending on the organ that carries the highest risk for causing harm to the patient, which may be the heart and just shock state in the first day, and then the kidneys, or maybe the lungs if they are flooded. So do you really believe we will have big pragmatic fluid trials in the future, and whether they will give us the answers?
I mean, I certainly hope we do have large pragmatic trials. I agree that there definitely is room for individualized or personalized medicine. It would be nice, though, to see like signals for benefit or signals for harm, because they're also very informative in large trials, because that helps guide where to go with our practice. I sometimes worry that we use personalized or individualized medicine or precision medicine as really excuses to do whatever we want. I don't know if Prof. Yaseen is still around, but I'd be interested in his thoughts also on the question.
Yaseen?
I agree with all the comments mentioned. Yes, I would like to see signal of benefit. For the balanced fluids, we have data on 35,000 patients, and sometimes you wonder, okay, how many more do we need? But certainly for certain subgroups, we do need more data, and that potentially can be achieved only by integrating research and clinical practice. Imagine you are doing this part of your clinical practice, maybe cluster randomized trials, maybe stepwise randomized trials, big, including large number of subjects. Then you can have enough power in your clinical trials. But for some questions, I think we have reasonably good number. Still, the heterogeneity is the issue. Mixing the all group of patients together, I think this is a challenge.
I also think sometimes like researchers like go into these studies thinking that their intervention, like balanced crystalloids or saline, for example, will decrease mortality by 20%. But as intensive care physicians, we know that mortality in these patients is multifactorial and that no single intervention is likely to have such a large impact on mortality. So we need to conduct trials powered to detect much smaller differences in patients' outcomes.
Exactly, and randomizing a patient takes time. And if you look at all the big fluid trials, it takes about 12 hours, 24 hours. Sometimes the total amount of fluid given before randomization is equal or even bigger than the study fluid. And in some studies like split trial, we're talking about 2-3 liters within 1 week. So you could basically say that saline is okay to give in small amounts within the first week to dilute other drugs in, but I don't believe that because I think that every bag counts, every drop counts, and maybe the sodium balance is even more important than the fluid balance, as even healthy kidneys take a lot of time to get rid of the excess sodium that is in abnormal saline. So do you think, Emilie, that in the future we will maybe see studies on the buffer, so the balancing solutions, as there is also the misconception that some believe that these are precursors for bicarbonate, but in fact the citrate, lactate, acetate, gluconate, pyruvate, whatever buffer you would like to choose, the main purpose is that it disappears as rapidly as possible to exert a strong ion difference and not necessarily generate bicarbonate. What is your...
I'm not aware of ongoing trials on that question, but I certainly hope we see them because definitely like people are using these solutions with I think an incomplete understanding of what happens once it is in the patient.
In your last slide on the future, you mentioned, okay, so balanced solutions, the type of the buffer that we use to create a strong ion difference, we just discussed. You also mentioned albumin as a natural colloid. It may have other properties like anti-inflammatory, antioxidants. It's a carrier for a lot of drugs, like if you have hypoalbuminemia, your furosemide may not work properly or get to the place where it needs to go. So what about albumin? Is it 4%, 5%, 20%? Is it a bolus or a continuous infusion? What should we...
You're also forgetting what is your albumin diluted in, right? Because some albumin products are in abnormal saline, some are in buffered solutions. So I think the albumin question is a lot more complex and multifaceted than we initially thought it was. And people who know what to do in terms of albumin infusions, I think probably fool themselves a little bit. There is a lot more uncertainty than we think at first glance when we start digging into the albumin question.
And what about bolus or a continuous infusion? Because I heard that giving boluses may be more harmful for the glycocalyx. But then again, if there is such a big insult, the glycocalyx is probably gone within minutes.
I mean, that's not data we reviewed for the guideline, but definitely like very interesting. I can tell you that in my practice and around me, I see people using albumin mostly as boluses. So it would be very interesting to generate data comparing the two practices.
Yep, I see Amr is joining. We're running a bit over time, but I would like to do the revote just to see if delegates changed their opinion, and we can do that very, very quickly. Is there any take-home message that Yaseen you would like to share with the audience? And then I will ask Emilie the same question.
I think these guidelines are particularly useful in avoiding the use of hypotonic fluid in traumatic brain injury. I would strongly avoid this. I think the use of balanced fluids comes out as a reasonably good signal in most patient groups compared to saline, with the exception of traumatic brain injury. The albumin debate in traumatic brain injury is interesting because it's based only on one subgroup, but it's a harm signal that cannot be ignored. So much to learn about choice of fluid, that's for sure. I hope that we'll see more evidence emerging in the areas we highlighted in the guidelines.
Thank you, Yaseen. Emilie, your words of wisdom.
I'd say like I went into this project thinking we knew what we were doing when it came to fluids, and I wrapped up this project being a lot more conscious of the gray zones and the unclear areas. But in general, I would echo what Yaseen said, like favor balanced crystalloids unless patients have traumatic brain injury. It is my main takeaway.
Thank you so much to our both speakers. Ahmed, Mady, would you like to share something?
Yeah, really, thank you so much for this very interesting, Prof. Manu and Prof. Yaseen, Prof. Emilie. Really, hopefully, I am a practitioner. I'd like actually to have the guideline to help me not to confuse me more. So I'd like actually to have, really. So I hopefully, with more evidence, with larger trials, to have the answers of the precise answer of the questions, which is making us on the bedside, doing it comfortably with giving balanced solutions for a specific type of patient. And I do like actually the individualization or the precision medicine, as you have mentioned, Prof. Emilie, to be implemented on the individual basis. Hopefully, inshallah, we'll go. Thank you so much for this interesting.
Thank you so much, Ahmed. Amr, if I am allowed just to go quickly to the re-voting. So
Yes, sir.
I'd like to ask everyone to go to menti.com on the URL browser, and then let's dive into the questions. Okay, so this is the QR code, is a bit different. So join menti.com and then enter the code 46582926. So we'll wait a little bit for everyone to join. And last time they asked in the chat to put the code as well. I think maybe people are using just one computer. Let's see who is joining. We have 14 online, so we will wait a little bit more. As I'm sharing, I cannot put the code in the chat myself. Okay. Please join everyone who is still with us. It's very important to see the evolution of your votes at the beginning and at the end. So now we just have the questions on the type of fluids that you use or will use in the future in critically ill patients in general. So take your phone, take your browser, or you can also do it on your desktop computer. Go to menti.com and enter the code 46582926. Okay, so it looks like we have a majority now for Ringer's lactate. I see now we have 60 people joining, so we wait a little bit for the votes to come in. I'm going to hide the results because psychologically people will always vote to the highest result. Okay, please join and cast your vote. Let's have a look. So still, some people will go for normal saline, and we discussed could be the resources, could be the costs, but I guess compared to the first voting, we have more balanced crystalloids now. So that was for critically ill in general. So what about those with sepsis, septic shock? take your phone, pick a browser, enter menti.com, and then when asked for, enter the code 46582926. So here in patients with sepsis, again, we have Ringer's lactate, plasma light. So those two together is a majority and less saline. So compared to the previous.
Dr. Malbrain, we cannot see the vote or the question on the screen.
You can't see it?
Mhm.
Wait. Okay. How does that come? I can share my screen. Let me share. And then where is my Firefox? Can you see it now?
Yes, very nice.
Okay. I apologize. So, okay, majority balanced solutions. If anyone wants to give a comment, Emilie, Yaseen, please feel free to go. Move on to the next question. So now patients with respiratory failure. We had discussions on restriction. We had some discussions on albumin. So here it looks like balanced solutions altogether, majority. So we see less saline. I'm very happy with that. So there's less sodium, less chloride, less adverse effects. Okay. Then we move on to patients with traumatic brain injury. I think looking here at the systematic review, meta-analysis, pulling together all the trials comparing saline with balanced, it's straightforward that this is the indication left for saline, and the other one would be metabolic alkalosis. For instance, if there are upper GI losses, then saline is a good choice. So TBI and upper GI losses, that would be my 50 cents. So now it's interesting because we had some vivid discussions in the Q&A. So what about a patient with AKI? Potassium of 6, would you give a balanced crystalloid that contains potassium? Very good. I think initially we had a large amount of voters going for saline. Nephrologists usually go saline because it doesn't contain potassium, but the opposite is true. Saline will increase potassium. So I think here a very good message that also in AKI and increased potassium levels, balanced crystalloids, even if they contain potassium, are a good first choice. Then we have patients with trauma, risk of bleeding. So here some of the balanced solutions may contain calcium, which is something that you may want in patients with bleeding. Okay, so I think except for those with TBI, with traumatic brain injury, for the others, balanced solutions are fine. Emilie and Yaseen, if you want to comment, please just unmute and give it a go.
It's nice to see the guidelines changing the way the attendees think. I'm hoping we can see these guidelines change the way they practice also.
Yeah, good
Fantastic.
point. And then now we move on to patients with cirrhosis. I think also there the guidelines made a clear recommendation, and we know that the evidence for most of the recommendations is not very high, but here we have some clear signals for albumin. I think also in patients with spontaneous bacterial peritonitis. Don't use albumin because the levels are low, or in patients with hypotension during dialysis, or to prime your extracorporeal circuit, but use it in patients with cirrhosis. And then severe acute pancreatitis and abdominal hypertension was not a specific PICO question of the guidelines, but my go here would be for isotonic balanced solutions. We had a discussion, Ringer's lactate sodium is 130, is a little bit hypotonic. And for resuscitation, isotonic is the best. So the more hypotonic, the more the fluid will go into the extracellular and also intracellular compartment as for glucose dextrose. Okay, I think then hopefully everyone will be interested and implement fluid stewardship in analogy to antibiotic stewardship in the future. Well, I should have rephrased the question. Will you implement it in the future? And I think it's clear that most of you will do so. So just 1 minute to introduce the basic fluid champion course, which is available in the members portal. It's free. It has modules on the principles of fluid homeostasis, fluid composition, fluids for resuscitation, maintenance and replacement, and fluid accumulation syndrome. So you always have a lecture, a tracked video, which is followed by a quiz. You need to get 80%, and then you can progress in the course. You can review the slides. You can view the correct answers to the MCQs. And at the end, you can get a EACCME certificate. So this was what I wanted to tell you to wrap up. And now I hand over to the president of WICCEM, Amr, please.
Thank you so much, Manu, and thanks, Emilie and Yaseen, Ahmed, and everyone. It was a very informative and thoughtful webinar today. I think you left us with a lot of unanswered question, and what we ignore, I think, is much more than what we understand. This is the reason that we are planning on series of fluid webinars for resuscitation. So the upcoming one will be focusing not only on the type of the fluid resuscitation, but also on the volume, on the amount we need to give. Then we'll talk about different phases, not only the initial resuscitation phase, but optimization phase, stabilization phase, then de-escalation phase. So everyone, please stay tuned for more information. We'll keep in touch, and hopefully we'll see you in a month or so. We'll let you know exactly the date and time for the next webinar. Thank you so much, and have a good rest of your day or a good night wherever you are.
Thank you, Amr.
Thanks.
Bye, everyone, and
Thanks.
see you next time.
Bye.